So this is an 88-year-old male with past medical history of COPD, peripheral vascular disease, hyperlipidemia, prostate cancer, and hypothyroidism, who presented to the ED for an unwitnessed fall. Caretaker was at bedside providing some of the history along with the patient. As per the caretaker, she found patient on the floor this morning. Patient was unsure about what exactly happened, didn't fully remember the event or what happened prior to the fall. Said he thinks he may have been down for about 20 minutes and he's unsure if he lost consciousness or not. Caretaker believes that the patient was more altered than usual at the time she discovered him on the floor, but in the ED she states he is at baseline. Patient only endorses not drinking much water in the past few days and also endorses a cough with green sputum. While he was in the ED, an x-ray showed left intertrochanteric fracture, and orthopedics was consulted for evaluation, and his troponin was elevated to 0.804, and cardiology was also consulted. A bladder scan performed in the ED also revealed greater than 600 cc's and a Foley catheter was placed. At this time, patient denies fever, tongue bite, loss of bowel or bladder function, dizziness or palpitations prior to the fall, although he doesn't remember. He denies any stool or bladder incontinence, any head trauma, or change in medications. His allergies include Cipro, Floxin, and Scepter, but he doesn't remember what the reactions were. And his past medical history includes COPD, dyslipidemia, hypothyroidism, prostate cancer, peripheral vascular disease. His past surgical history includes bilateral cataracts, bilateral inguinal hernia repairs, and an L5 laminectomy. He is never a smoker. He denies any alcohol use or any illicit drug use, and the family history is non-contributory. On further review of systems, he denies chest pain, shortness of breath, wheezing, nausea, vomiting, sick contacts, and recent travel. Vitals-wise, his temperature is 98.3, heart rate is 97, respiratory rate 20, blood pressure 139/84, and he's sitting at 94% on room air. In general, he's well-developed, well-nourished, he's not in any acute distress, and his head appears atraumatic, normocephalic. On eye exam, his extraocular muscles are intact, and his pupils are equal reactive to light. He is respiratory-wise clear to auscultation bilaterally, no evidence of wheezes or crackles, and on heart exam, his heart rate was irregularly irregular. On GI, his abdomen was soft, non-tender, normal active bowel sounds. His extremities had no cyanosis, clubbing, or deformities. On the hip exam, the left lower extremity is mildly externally rotated and shortened. He did have some tenderness to palpation of the left hip joint. On the neurological exam, he is non-focal, cranial nervous tooth of 12 are grossly intact. He is alert to person, place, and year. He is appropriate and cooperative. Skin is clean, dry, intact, and we didn't see any bruising on the left hip or erythema. So EKG in the ED showed a left bundle branch block and an atrial fibrillation, which has not been noted previously. Lab-wise, his white count was 16.0, hemoglobin 16.3, hematocrit 49.2, platelets were 264. Chemistries, his total CK was 1,244, CKMB was 11.0. Sodium was 140, potassium 3.9, chloride 107, CO2 was 22. BUN was 26, creatinine 1.43, glucose was 114, calcium 8.4, lactic acid was 1.7, and troponins were initially 0.440 and increased to 0.804. On his urine studies, he didn't have any billy, blood, or glucose in his urine. He did have some 1+ ketones, but no leukocyte esterase or nitrites. He did have a 1+ protein, 1 white blood cell, and 9 RBCs. No bacteria were seen. He did have occasional mucus. His INR was 1.0 and his PET was 10.9, PTT is 22.5. So they did a CT combo of the head and spine that found no acute intracranial process, and a mucus retention cyst in the left frontal sinus, and the cervical portion of it showed no acute osseous abnormality. X-ray of the hip showed an intertrochanteric fracture of the left femur, and a chest X-ray found no acute findings. So in summary, year-old male with past medical history of COPD, peripheral vascular disease, hyperlipidemia, prostate cancer, and hypothyroidism, who presented to the ED after an unwitnessed fall and then found to have a left hip fracture, rhabdomyolysis with CK of 1244, new onset atrial fibrillation with a troponin of 0.804, AKI with creatinine of 1.43 and baseline is usually 1.1 to 1.3. So for the unwitnessed fall, differential includes cardiac causes, possibly dehydration, maybe a mechanical fall or acute infection. So he's being admitted to step down with telemetry. We'll repeat the troponin and EKG, do CBC with differential for morning labs, and also get a procalcitonin, ESR, CRP, ammonia, urine drug screen, and blood cultures. For the left hip fracture, orthopedics has already been consulted, so patient will be seen and evaluated by them. For the rhabdomyolysis with a CK of 1244, we'll do IV hydration at 1.5 maintenance with LR at 150 cc's per hour, and we'll continue to monitor the CK, and we'll do a BMP in the morning. For the new onset AFib, possibly due to demand ischemia versus infection versus thyroid versus COPD versus some kind of cardiac abnormality. His CHATS VASC is 3 and his HAS-BLED is 2. Dr. Jothidasan with cardiology has been consulted, and he says since heart rate is stable and patient is asymptomatic, he thinks anticoagulation can wait until patient has hip repaired. He recommended starting topical tartrate at 25 milligrams BID, so we'll start the first dose today. Repeat EKG and troponin are pending. Magnesium, phosphate are also pending, and we'll keep looking at the other electrolytes on BMP. Echo was ordered, and we'll also be waiting for the TSH and the urine drug screen. So problem number 5, acute kidney injury with creatinine of 1.43 with a baseline of 1.1 to 1.3. Likely secondary to dehydration or rhabdomyolysis. So we'll continue with the IV hydration as above, and we'll continue to monitor the renal function. For his chronic conditions such as the COPD, we'll continue his home medication of Advair, Zopinex, Spiriva. And for the hypothyroidism, we're checking the TSH, but we're also going to continue his home medication of levothyroxine at 125 mcgs. For the urinary retention, which was found in the ED, unknown etiology at this time, we'll just continue to monitor that. So fluid-wise, we're keeping him on LR at 150 cc's per hour, and for diet, we're keeping him NPO after midnight for possible surgery tomorrow. DVT prophylaxis are SEDs for now, since he might be having surgery, and patient has already received a one-time dose of Lovenox. Code status is DNR, and we expect him to stay for longer than 2 midnights.